Hello, everyone, and thanks for joining the Best Practices for Improving Clinical Workflows in Your EHR webinar. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being recorded and will be available to you for future viewing. Throughout the session, all attendees will be in listen-only mode, so if you have any questions, please type them into the questions section on your GoToWebinar console. At the end of the presentation, we'll have a Q&A session as well. We'll try to get to as many questions as we can, but if for any reason yours was not addressed, someone will be able to follow up with you after the presentation. We like to keep things interactive, so throughout the webinar, we will be launching poll questions for you to answer. Today, we have IMO Physician Informaticist, Dr. Jim Thompson. As mentioned before, if you have any questions or comments while our presenter is speaking, please type them in with questions on your GoToWebinar console. And with all of this being said, I would like to pass it over to Dr. Thompson.
Thank you, Jory. Hi, folks. My name is Jim Thompson. By way of background, I spent most of my clinical career in the emergency department. I have boards in internal medicine and emergency medicine. And I also spent about 10 years as a CMIO in the western suburbs of Chicagoland. During those 10 years as a CMIO, as we were building out our electronic health record, one of the most significant things that I had to deal with as the EHR was being developed for us and really across the nation is the kind of workflow that's built into the electronic health record. And so that's what I want to chat you up today about a little bit. Talk a little bit about workflow and workflow automation by way of background, some of the challenges, and then some examples of how we might overcome those challenges. And as Jory mentioned, if you have any questions along the way, feel free to type them in and we'll try to get to those at the end. Why do we care about clinical workflow in the first place? Well, what you're looking at here is the typical Gartner hype cycle curve. You can think of that vertical axis as being related to satisfaction or hype or that sort of thing, and the horizontal axis as being time. And if I think back to the late 90s, when I first started taking over the electronic health record at my home institution for the clinicians there, now, there was this idea that if we went from paper to electronic, nothing was going to work very well. So the hype around that kind of dropped a little bit. And then in the early 2000s, along came an idea that we could use the electronic health record for order entry. We could use it for documentation. It was going to be much faster for us to get all our information in one place. We didn't have to fax stuff anymore, on and on and on. And the excitement level was pretty high. And then the reality started to set in so that we, like most other organizations, I think, dipped down into what Gartner calls the trough of despair, the red circle there. And over the last 10 years or so, what I've noticed as an informaticist, and in my job here at IMO, I had the privilege of working with many, many customers across the whole country, is that as a billing tool, the modern electronic health record has really been pretty successful. I mean, I can take care of a patient, drop the encounters on the bill, have all of that get sent off in an automated fashion, and get paid reasonably efficiently for what I do. At the same time, though, as a clinical tool, the electronic health record hasn't really lived up to some of the expectations. A problem-oriented electronic record that we've been hearing about since the days that Larry Weed started promoting it almost 50 years ago just has never seemed to have materialized as successfully as we had hoped. And I think that a great deal of that disappointment, that lack of enthusiasm over the benefits of the electronic health record for the clinically oriented physician is related to workflow. So what do we mean by workflow? Well, if you think about what I have to do in the clinic, what workflow means to me as a clinician is a recurring pattern. In other words, I have to do a particular task with an end goal in mind, and I do it in a certain number of steps. It's frequently quite a few steps, but they're fairly predictable steps that cumulatively drive a pattern. And what I'd like as much as possible, if the electronic health record is going to help me, is to have as much of that workflow automated as possible. I don't want the electronic health record to be a set of discrete, disconnected manual steps that I have to do individually in order to make an actual decision. So I want to use the information technology to facilitate that workflow as much as possible. Clinical workflows are complex. Although the steps for me to generate a prescription are similar, I see the patient, I think about what they need, I put that in the context of what they're already taking, what their allergies are, and so on, and write the prescription. There are quite a few complex nuances to that. If I want to do something as simple as refer a patient for a clinical consultation, I have to determine maybe what their where they live and who the specialists are that I might want to send them to, and maybe even what insurances they're allowed to use, and so on. So there's a lot of complexity inside there, and that means that the workflow itself has to be flexible. It also has to be multi-directional. It's not just me doing everything in one discrete series of steps at exactly the same moment. There might be multiple times when I need to get feedback from an insurer, from a potential consultant, and so on. And so all of this makes the complexity around actually automating that clinical workflow quite hard for an electronic health record to handle. Let me give you a fairly simple example of trying to automate clinical workflow for a clinician. What you're looking at on the screen here is an actual problem list that I collected from a patient who was sent to a colleague of mine. This is a number of years back. But here an effort was made to automate the workflow around a problem list. Now, the problem list, as you know, is sort of my center point of care. It's where I go to see what's going on with the patient. If you come in to see me with a cardiac problem, I want to know what's going on with your cardiac stuff in general, so I can put that particular problem in focus, and then I probably need to get an overall clinical picture so I can put your overall cardiac status into your overall clinical picture. And what somebody tried to do here is to say, well, it's really tedious for a physician or a PA or a nurse or other clinician to actually enter those problems into a problem list. So here's what we'll do. We'll have a computer go in and grab all of the encounters that ever got put on this patient's diagnosis as they were heading out from a previous encounter. We'll gather them all up and we'll stick them into a single list. Now, this is on the one hand, theoretically terrific. I mean, I now have in a single bucket all the stuff that anybody said at discharge for the encounters for that patient. But as a practical value, it's not very useful. For one thing, it's in print. I need it to be electronically manipulatable so I can take stuff off there and put it on there more easily. And for another thing, it's not organized at all. So maybe the first thing that we need to do to automate this particular workflow is to say, well, let's make it neat and let's make it editable. And that's what a computer has done here. And this is a real world problem list from my home shop, and all the problems that have been entered onto this patient's problem list are right here in front of me. So that's already a big step forward. For one thing, I can clean up any automated process that landed problems on there that I didn't like, even though it might be kind of tedious to do that. But to make it more helpful, I'd like to automate this workflow into a way that categorizes those problems for me. I'd like to have the computer say, look, here's the GI stuff, here's the cardiac stuff, and so on all the way down. And then if I could really automate it the way that I would like in my perfect world, I'd be able to say, well, right now, this person's here to see me for a given cardiac problem, but gee, they think they've been exposed to COVID-19. And so is there any way you can help me with whether or not this patient is at particular risk for that? And one way to help me would be to call out from that list all of the problems that represent an increased risk for that particular patient. So that's the kind of automation example for the workflow just around getting a clinical picture of a patient that I would find extremely helpful as a clinician. Now, even though I've made some criticisms of the electronic health record, it's not the case that we haven't made any progress at all. We really have along the way, if you think about it, even though we as clinicians still tend to complain quite a bit. In my electronic health record, as new labs come in, they get sorted to the top, they get tied to that particular patient automatically, even if it's from an outside laboratory. If a particular lab is out of reference range, it gets flagged and sorted to the very top for that patient and so on. If I give a vaccine, then automatically in the background, the inventory is tracked. So if I've given the same vaccine 3 times and I only have 2 more left, I can get a flag for that. I have a little task list that I can mark as done or not done or in process. I have the ability to say, well, I need to change some of the intake questions. If Ebola happens to be a current concern in the country, I want to know whether or not this patient has traveled. So I want that question asked during the intake process. And even with something as complex as clinical decision support, when the CDS there, the electronic record has made huge strides. Right now, I'm able to say, all right, there's a new requirement that if I have an advanced image that I want to order, I need to pick from a drop-down what the reason for that is. So that's already built into the electronic health record. And then if my electronic health record requires me to tie that advanced imaging support into the encounter diagnosis, I can even have the encounter diagnosis automatically populated to support me there. So it isn't that we've made no progress at all. It's just that there are some challenges that still remain. And if you look out into the industry magazines, I think you won't have to look very far to see the kind of quotes that you see on the screen here. You won't have to look very far to see a lot of criticism is left of the electronic health record, that it costs me time, and every moment that I have to spend in front of the computer, so to speak, is a moment that I don't have face-to-face with a patient. It still seems like so many processes feel very tedious. The commonest complaint that we at IMO hear as feedback from our clinicians is that no matter what task I want to do, I have to click and click and click to get through it. Physicians do literally count clicks, and all the way down to the wish that we were back on paper. I don't think anybody anymore really wishes that they were back on paper, but it does feel a little bit frustrating sometimes to deal with the modern electronic health record as we have it today, and it does seem like there's some room for improvement. What are some specific challenges? Well, if you look at it from the perspective of a vendor or the perspective of the folks who are in executive positions at your organization, there are a host of administrative and regulatory requirements that disrupt ordinary clinical workflow. These requirements come from all over the place. They might come from an organization that overlooks a documentation and says, hey, if you're really going to document properly along the lines of XYZ for a problem, you need to include the following elements. They might be regulatory requirements that a vendor has to do when they're building out an electronic health record so that they comply with government regulations before they even sell it in the first place. Then there are the constantly evolving requirements of technical advances. You know, if you go back 20 years, you had to go down to the radiology department to see a film that was posted in the department on a physical piece of celluloid. And then along comes a picture archiving communication system, or PACS, where now we can make that image digital and send it anywhere. That's terrific, but it all has to be integrated into the electronic health record. And all of these new technical advances come along so fast that sometimes from the vendor perspective, just keeping up with the new technical advances is extremely complicated and makes it more difficult to focus on workflow. Things like images that now need to be embedded. I think going forward, we'll see more and more videos being embedded as more and more surgical procedures, for example, are literally filmed from the time you open the patient until the time that you close the patient. Initiatives like patient feedback directly into the chart, where the patients want to be able to annotate their own records. All these kinds of advances really make it difficult for us to focus on workflow automation. And then I think to a certain extent, and maybe to a large extent, there is an increasing complexity of clinical care and decision making. There was a time when I, as a primary care physician, knew what was going on with my patient. I was pretty much their only doctor unless they had to go see a specialist. The chart was my notes to me on paper. And now in the electronic health record world, there might be a dozen clinicians entering data that now all needs to be brought together in order for me to make a really good decision. And medicine itself, of course, grows increasingly complex every year with more and more nuances, more and more advances. And so to take me from this enormous library of data to making an actual decision about a patient depends on accumulating all that necessary data from every single point in the record, and then, and perhaps just as importantly, presenting that data to me as a clinician in a really meaningful way. So that's really what underlies this whole idea of automating workflow, bringing all of this information together into one place so that I can make a reasonable judgment. You know, take, for example, a patient who has a problem list, the bottom left of the triangle here, and on that problem list is the fact that they have a renal mass that may need to be biopsied. Also buried somewhere in that problem list is that they have a history of deep venous thrombosis. In the host of medications they take is the fact that they are on warfarin. This is going to play into a decision of how readily I can biopsy them, and perhaps even how that biopsy should be done, by needle or open biopsy. And then over on their laboratory report side, they've got an elevated INR. So not only are they on blood thinners, but they're on too much blood thinners. Well, I have to gather all that data together and form an overall clinical picture out of it. Patient has a renal mass, they've got a history of DVT, so they're on warfarin, their INR is out of range. That's my clinical picture. Now that data becomes information, and out of that information, I have to make a judgment. If my judgment is to do a renal biopsy, I have to do it with coag management. Bringing all of those elements together into a single coherent picture so that I can make a decision is exactly what automating workflow is all about. So let me take a pause here and have Jory put the poll question up about the overall impact you might see on clinical workflows in your organization, weighing the good along with the bad.
Thanks, Jim. If you all could refer to your screen, please take a moment and answer. All right, just a few more seconds. Awesome. Thanks so much.
Great. Thanks, Jory. Let's talk for a few minutes about some strategies for optimizing the electronic health record workflow management. The first one that you see on the list here is very dear to my heart, and that's to emphasize the importance of display. In the non-electronic health record world, all of us have seen our computer screens go from, at least those of us who are old enough, have seen our computer screens go from the infamous green screen that's nothing but text and a background color, and sometimes not even a changeable background color, to really slick interfaces. Well, sometimes the slick interfaces are overdone, but nevertheless, I would say that the first thing to focus on from a clinical perspective when you're using the electronic health record is how that information is actually displayed to me. Second thing I'd like to mention is documentation templates and where they can help you, delegating tasks, follow-up reminders and ticklers, customizing your clinical decision support, and then finally I want to mention cleaning up the content of the electronic health record itself. Let's start with the display. Imagine that I'm an airline pilot. I have thousands of things that need to be kept track of to keep that plane flying safely. There is no way that I, as the pilot, can keep track of all of them. So most of them have to be automated. And what I need to see is a display that's kind of a summary of everything that's happening with the airplane that's presented to me in such a way that I have a little dashboard. And on that dashboard, most things, most of the time, should look pretty normal so that if something gets out of line, it's really obvious exactly what happened. In other words, this dashboard lets me accumulate all the information. It's all there if I need to go into it. But if there's one particular thing I need to focus on, it's really easy for me to see what happens. Let's take that idea and bring it over to the electronic health record. So imagine that I'm looking at a problem list like the one you see on the right-hand side of the little screen capture here. That's pretty useful. That's similar to the problem list that I showed you before, but even better would be if I could categorize that whole list so that I could see the cardiac stuff and the endocrine stuff and so on all the way down the line. Now I still have to manage the patient for a particular set of problems, and any problem is related to its labs and meds, for example. So the next level of automation would be for me to have the computer bring forward to me the things that are related, for example, to the endocrine issues or the diabetes issues. So here are the meds that relate most specifically to that particular category are brought forward for me. And then the same thing with the labs. You know, every patient has got dozens and dozens of labs on them, but what I would like to be able to do is say, well, that's great, but right now I'm focusing on this patient's diabetes. What can you bring forward that's germane for diabetes? So just that little idea of display and bringing all the data together so that it becomes information for me out of which I can make a judgment. That idea of the display itself is huge. It's not just that the data is, it's how it's brought forward to me as a clinician. A lot of this is, of course, on the vendor side, so maybe this piece you could think of as directed a little bit more toward those folks who are actually designing the electronic health record. But here's something that most of us can do within the electronic health records that we already have that is frequently quite underemphasized. Personalized documentation templates. These aren't great if I have an encounter with a really complicated patient who's got 5 different things going on with them. But that's not the typical patient, and that's not the typical encounter that I have who comes into the clinic. Those encounters tend to be more focused on a given chief complaint that the patient has come in with. So once I get an overall picture of what's going on with the patient from the problem list, now I can go into the need to document that particular chief complaint, what's going on, what I need to do about it, what my assessment is, and what my diagnoses are to send off for billing. If you personalize these documentation templates properly, they can be an enormous time saver. It really is worth going down this tree because almost every electronic health record out there has these sorts of documentation templates built into it. So if it's a single problem visit or routine preventive care, it's a regular straightforward procedure, lots of other discrete bits of documentation, find the documentation template and get used to how you use it. This is also going to help you avoid errors of omission. There are so many things where something that happens in the clinic should create an automatic documentation around something, an automatic order, a follow-up, whatever it is. And having a template there is kind of like having a checklist of what to do so that ordinary errors of omission don't happen. And then most of them will have links to common orders, prescriptions, patient education handouts, the other kinds of busy work that feel like they're kind of tedious, but can be relatively automated if you've got a good documentation template. And most electronic health records do allow tailoring these for both the department and the individual user level. Then there's this idea of task delegation. What we find when we talk to individual clinicians, especially those who tend to be in small practices, that the physician himself or the PA herself tends to feel like they have to do everything, but the provider doesn't have to do everything. There are any number of tasks that can be automated in the background by other people to help your workflow go faster. It might be a simple visit, say just for a vaccination. It might be something done on the phone against common minor conditions that are fairly straightforward in terms of how they need to be managed and so on. So try and learn to delegate as many tasks as possible so that the clinician herself doesn't have to do all of them. And then for physician order entry in ambulatory settings, there's a great deal that can be automated there. So take a look at what the opportunities are in your electronic health record and see how many tasks can be delegated out to other people so that the clinician doesn't feel like they have to do all of them. Another one that's really helpful for workflow automation is to learn how to manage your follow-up reminders. There are so many things that when they occur need some kind of follow-up. Without an efficient way to manage those reminders, they're going to get lost. I recall from my own clinical experience that one of the biggest errors I ever made was a patient who had had a biopsy that was abnormal. I didn't put in a tickler to myself to read it. The pathology lab did not get back to me properly, and the only thing that saved me in that instance was the patient herself getting back to me to ask to follow up on her biopsy. But if you think of major things like that, or even little things like an isolated blood pressure reading that needs to be repeated, or maybe somebody comes in with some complaints that you think, maybe there's something, maybe they're not, let's see how that develops, and you need to follow up on that patient to see whether or not it did in fact develop, or something as straightforward as someone who gets the first set of their 3 hepatitis vaccines and you need a reminder to give them the second and third set. Learn how to use those reminders in your electronic health record so that the pop-ups come up in such a way that your workflow is substantially automated for not missing things that you otherwise have to have a post-it for somewhere that may get lost. For clinical decision support, or CDS, the experience is very mixed. out there. I mean, when the idea of clinical decision support came along in the electronic health record, it was treated with a little skepticism, I would say, but also quite a bit of enthusiasm on the part of some people, because now we were going to be able to have third-party providers even who created clinical decision support for us in our electronic health records. We're going to be able to reach out to those third-party providers and find out what to do in a given situation and so on. And some of that is still a little bit pie in the sky. Some of it is still far enough off that many providers find it unhelpful. For one thing, the logic doesn't always follow exactly the way that clinicians think, because you have to take what your original group writing the CDS did to convert clinical decisions into computer talk, so to speak. Sometimes the information isn't in your electronic health record, and right now EHRs haven't been very good in being able to reach out to third-party providers for their CDS. Sometimes the information's in the electronic health record, but the CDS isn't looking in the right place. You know, it's not checking the problem list, it's off looking somewhere else for elements that need to go into that clinical decision support rule. And sometimes the clinical decision support itself is perfect, but I just don't need it right that second. So it just becomes an alert or something that pops up in my clinical workflow that would be great if it were at the right point, but I'm not at that point in my overall workflow, so it's not helpful. Well, the message here is that your clinical decision support is probably more configurable than you think it is. If your alerts are coming up too often, go in and see whether or not you can tweak it. And the best example of this on average are drug-drug interactions. If you were to take a drug-drug interaction clinical decision support alert rule and set it to the most sensitive level, as the clinicians on the call are well aware, every single drug interacts with every single other drug. At least that's how it feels sometimes. And so you just get pop-ups all the time that aren't helpful. And one of the things that clinicians learned early on with the electronic health record is that even though a given alert may have seemed great in theory, in practice, if it happens too often, it doesn't take very many extra times for the clinicians to get alert fatigue. So take a look at your clinical decision support configurations and see whether or not you can tweak them so that alerts do not come up all the time. You may be surprised at how much configurability is available inside your electronic health record. And then another area that is also dear to my own heart with my work here at IMO is that over the years, the electronic health record has become kind of an addict because it never forgets anything. When we were on paper, and paper was all over the place, there was probably just as much data there, but because it was all over the place, I didn't really have to deal with it. If somebody else made a long cluttered problem list and mine was neat and clean, that wasn't an issue for me because I didn't have to clean up their long and cluttered problem list. But now with the electronic health record, the paradigm is that multiple clinicians who are taking care of the same patient are all feeding into the same database. And of course, the computer never forgets anything. So every scrap of paper that was ever imaged, every drop down that was ever acted on, every note that was ever done, on and on and on, are all in this giant attic of data. What I'd suggest is to start with the problem list as an area to start cleaning things up. I'm particularly passionate about the problem list because that's the work that I do here at IMO. But the reason that I'm so passionate about it is not because of my role at IMO, it's because the problem list is supposed to be the place where I can go to get a rapid, clean, clinical picture. I can only do that if the problem list itself is clean. So think about what kind of workflows you might be able to enact that actually help you clean up the problem list as one place to start. You will notice if you're a reasonably large organization or if you have multiple clinicians, feeding into the problem list. That this is one area where a lot of redundant data actually makes it more difficult for the clinician to get a clear clinical picture each time that patient comes in. You know, if you have a 20 or 30 or 40 problem list, which is not unusual in our industry in a large healthcare setting, what happens is that it doesn't get used at all, because I can't go into a large problem list and figure out what's going on with the patient. Even if I organize it, if there are 7 ways that somebody has said back pain over the years and they're all sitting on the same problem list, I may never get to the other important areas of the musculoskeletal issues for that particular patient. So one place to focus is how you might go to clean that up. Here's an example tool where on the left-hand side, redundant or duplicate or outdated problems are gathered together in little groups, and I can use the tool to create a much more efficient view by moving off of that actively displayed list the problems that I don't need. So check your system and your policies and see whether or not you can improve your overall workflow just by improving the problem list. A few closing thoughts here. One is that the electronic health record continually evolves. From an analyst perspective, this is sometimes frustrating. Almost every electronic health record vendor or terminology vendor such as IMO are constantly updating what we want you to take in. I know that's frustrating, but at the same time, think of the huge advantage it is that over time, your electronic health record gets continually improved each time that you take a new release from a vendor to make it better. But there are things that individual organizations can do as well. Almost every healthcare environment has groups who come together and try and think about ways to improve what's going on in their particular electronic health record environment. Encourage participation in those groups. It really does make a difference. Some of them are vendor specific, some of them are professional societies, some of them are in your home organization. It's tough, I know, to get clinicians to participate, but it really does make a difference. And what we notice at IMO is a relatively vendor neutral organization who works across lots and lots of organizations, many of whom own exactly the same healthcare record, is that at some organizations that exact same healthcare record is highly adopted, literally loved by its clinicians, and in others, the exact same record is a source of frustration. And it's amazing how often the difference between those two is the degree to which the clinicians inside that organization are willing to participate to actually improve their workflow. So encourage that from your side. Leverage your organization's IT and informatics resources. Everybody has limited resources. I understand that. But to whatever degree you can, if you leverage those resources to improve the workflow with the tools that are already in your electronic health record, you may find a substantial change in the satisfaction of it. And then finally, let your electronic health record vendor know. I know this is true from personal experience. At IMO, we work directly with customers and we work directly with vendors. And as I mentioned, we work across many kinds of electronic health records and therefore across many vendors. And almost universally, when we go to a vendor with a recommendation on how something might be improved with respect to workflow or terminology or anything else, a vendor listens to us And the vendor will frequently say, you know, that really sounds great. Would you mind giving us some customers who have that issue and let us talk to them directly? Because when we hear it from customers, it's a lot easier to drive our internal development. So I want to reassure you that if you reach out directly to your electronic health record vendor, even if it seems like something doesn't change the next day, it really does make a difference. It really is like an individual vote making a difference on something that needs to go in a particular direction. So keep those channels open and make sure that you give feedback to your electronic health record vendor on a regular basis. All right. Well, I'm going to pause there and leave some time for any questions that might come in. So if you have any, type them into the chat box. And Jory, I'll turn it back to you to look over that.
Yeah, thanks, Jim. That was great. If you have any questions, feel free to put them in the questions section of your GoToWebinar console. And please excuse any brief silence as we look at questions coming in.
All right, Jory, let me start with the first one, which is kind of tough, but I think it's a great question. There are a lot of different workflow challenges to tackle. I totally agree. Where do you see the typical hospital starting? Well, you know, one of the things that I learned as a CMIO is that if you've seen one healthcare system, you've seen one healthcare system. So it is different for each organization. But one of the things that I learned was that it was so important for me to have a channel inside my healthcare organization that solicited feedback from my clinicians, from my physicians and my PAs and my nurses and my techs and basically anybody who was involved in healthcare, that find a way to create a channel that makes it really easy to collect the feedback. It's, you know, we kind of think that if somebody has a complaint, they're going to say something. And I learned the hard way that isn't true. I learned the hard way that unless I literally went out and interacted with my clinicians, I didn't have a good feel for what they really complained about. And then or what they thought could be improved. And then the second thing is, if you get a specific item of feedback, I think it's worth checking how broadly distributed that particular feedback element is. There's just one guy who tends to be a squeaky wheel, and you know, he wants something fixed that's going to take you a huge amount of time to configure and fix, and then it turns out nobody else really wanted it or cared. So have a channel open, and when you get a specific element of feedback, take it to the broader audience of your clinical users and say, hey folks, is this an issue for us? And then that's where you want to start your focus. You want to start your focus on something that if you spend resources to configure it or otherwise fix it, it's going to fix it for a lot of people. It's not just going to cater to one person who has kind of a one-off idea of how things should be done. And that, by the way, I think is why vendors want to hear from multiple customers. It's why you should be giving feedback to your vendor. If there's only one customer that wants something, the vendor isn't going to rank that nearly as highly on their list of to-dos that they have to get done by the next release as if they hear it from 10 folks. So open a channel, find out what the complaints are, what the issues are, and try and vet them out against the broadest audience you can before you tackle a particular area.
Just a reminder to put any questions you have in the questions panel.
There's a very specific question here related to one channel, as we call it at IMO, and that is, can we, IMO, offer a cleanup tool for NextGen? We're working on this for some of our customers. We have it deliverable for some of our customers, and we'll work on it for NextGen in particular. One of the challenges that we have at IMO is that each electronic health record is a little bit different. So when we create something, we can do it on our side, and then we have to make sure that it's easily iteratable in a given channel. We have done some really cool things with NextGen, as those customers know, and I think we'd like to work on that, or we are working on that currently. Next question is, in my experience, do I think that workflow improvements help to address physician burnout, and if so, how? Absolutely. They make a difference. The number of physicians, and I would say maybe particularly in an older age range, who go back to paper days and remember how easy it was to write up a patient, even if it wasn't very good, it was still easy, who then were coerced by legislative requirement or billing requirement, or just the general movement toward an electronic health record to move to an electronic health record. The number of clinicians who have complaints about that is still pretty high, and it does burn them out. And so whatever we can do to improve workflow helps improve that burnout. And the experience that we've had with customers, even to the extent that clinicians will change from one organization to another, or change their affiliation just because of the electronic health record that they have to work inside. And the obverse of that is true as well. If you can make your electronic health record really satisfying for your clinicians, it helps you recruit clinicians, and it helps you bind clinicians to your organization, because it's a great place to work. Every clinician, I think, at some level likes to work with patients, otherwise they wouldn't be in clinical medicine. They would have already moved on somewhere else. And so the degree to which you can let them focus on working with their patients clinically and not just dealing with the electronic health record keeps them happy and keeps them bound to your organization. And these days, where patient satisfaction is so important and is measured by every single healthcare organization out there, the ability to recruit and retain clinicians just because you're keeping them from getting burned out is huge. The next question is that it seems like this is a project that crosses service lines and specialties. Would you suggest creating a core team to review and identify prioritizing modifications? If so, any suggestions on who should be part of the team? So I'll lean a little bit on my experience as a CMIO here. Yes, any project that you undertake is likely to cross service lines and specialties. Most modern organizations that are any more than a few clinicians have different specialties, and the ones that are able to do any kind of configuration that have the sort of a team to do it tend to be larger kinds of organizations. And yes, I think you have to have a core team to review and identify prioritizing modifications. Most organizations that we come across do have that somewhere. In terms of who should sit on that, at a bare minimum, representation from several specialties and from a fairly broad primary care team. I think the primary care clinicians are the ones that kind of bear the biggest burden where the electronic health record interacts with dealing with patients. So primary care. But then I also think it's equally important to extend out beyond just the physicians. And this is another little passion of mine. And I think particularly of nurses, I'd lump the PAs, the physician assistants, in with the physicians. But I think that nursing representation is critical. Nursing, especially inside the hospital, tends to feel like they have to just take whatever they're given for the electronic health record. But if you think about it, there might be a multiple of 10 nurses for every clinician that's actually using that electronic health record to take care of patients. So make sure that nurses have full representation on any core team that's suggesting any modifications to your electronic health record or issues with it, or anything else related to it. And then at my own organization, we extended it out beyond just physicians and nurses and try to get at least a sampling of folks like pharmacists or radiology techs or other kinds of people who also interact with the electronic health record. So in summary, I would say as broad a representation as possible, because you have a limited number of resources who are going to actually be able to execute the modifications that you want to do, the configuration, fine-tuning that you want to do that floats to the top of the list, and you want to make sure you're spending your resources for the broadest possible benefit. There's one other question here before we close that is fairly germane to IMO. I'll go ahead and try and tackle it. I want to reassure you that from IMO's perspective, our objective here is not to pitch IMO. Our objective is to share some of the things that we've learned in dealing with healthcare organizations across the country, and do so in such a way that it's helpful for you, and not necessarily a pitch for something that we're doing. But the question is, why doesn't IMO offer a decision tree for all of our diagnoses? If by decision tree you mean anything related to clinical decision support itself, the short answer from our perspective is that we haven't tackled that as a business yet. We can't do everything. We're deeply interested in how well terminology works for you. We're deeply interested in how your various dictionaries are for things like surgical procedures, and how we can support the electronic health record itself so that the electronic health record in turn supports you. But we haven't gone down the road of creating decision support de novo. We haven't gone down the road of being a clinical decision support creator yet. That may be coming, but right now it's just not what we're doing. Did that answer that question adequately? I want to make sure that I understood the question.
I think you did, Jim.
Okay. All right, Jory, I'll turn it back over to you. If there are any other questions, I can clean them up. And otherwise, I see we're pretty close to the top of the hour.
Yeah, I think we're going to go ahead and close out for today. I hope you found everything, valuable, and Jim, you did a great job. If you want any more information about IMO, please contact your IMO client executive, and you can also email them by sales@imo-online.com. Thanks for attending today, and I hope everyone stays safe out there. Thanks. Bye.
Bye now.